system would just have the neuron cell body in the central nervous system, and you just have one axon that goes all the way to the skeletal muscle. That's not how the autonomic nervous system works. The autonomic nervous system has two neurons on the way, okay? So it's a series. But of course, you know enough anatomy to look at this and tell which direction information is flowing, right? Yeah, you know enough anatomy and enough physiology. Okay, so with that in mind, you could look at both of these, and with the direction of information flow, you could tell me whether you're looking at sensory or motor activity. Can't you? Yeah, it's going out, so it's going to be, does that make sense to you? Okay, so this is going to be motor activity. So what you're going to see in your textbook whenever it does it in this chapter and in other chapters is it's pretty consistent that this first neuron is going to be brown and the second one's going to be blue. They are not that color in the body, of course, right? They're just trying to be consistent so you can gather the information from one figure to the next. And so what's going to happen is the neuron cell body of the first neuron is going to be in the gray matter of either the brain or the spinal cord, depending on whether you're sympathetic or parasympathetic. This first neuron is in there. And then this axon will run to a ganglion. And remind me what a ganglion is. Neuron cell bodies in the peripheral nervous system, not the CNS, right? So it's only showing you one, but there's a bunch of them in there. Okay, so this is going to be a ganglion, and specifically because we know the functionality, we can call it an autonomic ganglion. This one's a motor ganglion, not sensory. The only other ganglion you've looked at thus far was the dorsal root ganglion, which was sensory. This one's a motor one, okay? So this will stretch here, and then the second neuron, its cell body is in the ganglion, and it stretches to the effector. And the effector's choices you have for the autonomic nervous system are three types of tissues. What are they? Cardiac, smooth, and glands. I think this one is trying to show you smooth muscle, right? Okay, so with that in mind, and because we understand the whole directionality of information flow, we call this one the preganglionic neuron or axon, and this one's the postganglionic. Yeah? Okay, so here's something that's weird. With the autonomic nervous system, I don't understand this, and I've never come up with either a conceptual description that makes sense to me or an evolutionary description that makes sense to me. Maybe you guys can come up with one, and it'll make me happy, because generally in anatomy, I can make things make sense. I can be like, oh, okay, that makes conceptual sense. This doesn't. Okay, with both of the sympathetic and the parasympathetic nervous system, the preganglionic neuron is myelinated, and the postganglionic one is not, okay? And that's fine. I don't know why it occurs, but that's not the part that confuses me. And then the other thing is that with the sympathetic nervous system, the preganglionic axon is short, and the postganglionic axon is long. Now, before we get to what confuses me, that means that with one branch of the autonomic nervous system, the ganglia are going to be right next to the spinal cord. Which one, sympathetic or parasympathetic? Sympathetic, because the preganglionic axons are short, right? That makes sense? So what you are going to see, just to show you that before we talked about what's confusing, is that you will have a chain of ganglia right next to, lateral to the spinal cord on each side, okay? And those are called the sympathetic chain ganglia, or sometimes the sympathetic trunk ganglia. Now, you don't usually see them in lab, not because we can't dissect them, but because the dissection that we would have to do to show them to you destroys all of the organs in the thoracic cavity. So let me show you where they are. So this is the aorta, just for orientation, and these are, of course, the ribs and intercostal arteries and intercostal veins. So where you would find the sympathetic chain ganglia is spaced pretty much in the intercostal spaces, or right next to the intercostal spaces on the posterior thoracic wall. And so we don't usually want to devote an entire cadaver to showing you those structures. Although Christy, one of the lab aides, is doing that dissection right now. She's pulled everything out, preserved the heart and the lungs and everything, and the blood vessels, and then she's identifying all of these. So it may be in there next semester. So they are not impossible to see. They're just really, you have to devote an entire cadaver. So those are called the sympathetic chain ganglia, and they're on either side of the spinal cord. Okay, so what is the thing that's confusing? So, sympathetic or parasympathetic? Which one is going to be most important in an emergency? Sympathetic. So it seems to me that the sympathetic should be faster in its response time, right? But do you see how this setup makes it look like this one would be slower? Because we've got a unmyelinated long axon and a myelinated short axon. Does that make sense? And this one is a myelinated. So that's what I just don't understand. I'm like, what the hell? Why is it like that? And I haven't found anybody who can give me an answer that makes sense. The possibility exists that I just don't know the right question to ask, or the possibility exists that it could also be one of those evolutionary anomalies. Like, why did the decussation of pyramids occur? Because it did at some point. So I wish that I had some explanation for this one, but I don't. This is like pooping, and there's a freaking bear, right? Right? So I don't know what that is, but the impact of the short and long preganglionic axons means that your ganglia are going to be at dramatically different places. So, of course, with the sympathetic nervous system, the ganglia are going to be pretty close to the spinal cord. By the way, this ganglion is not out here. They just pulled it out so you could see what was synapsing out there. They're actually here, close to the spinal cord. And but where are the ganglia going to be with the parasympathetic nervous system? Look at the brown. Look how long it is. The ganglia are sometimes on the organ, right? They're all the way out there. And all of this is myelinated, and that one's not. So I'm like, what? I just can't get it. I don't know. So if you guys come up with a phenomenal explanation, let me know, okay? I want you to educate me. Hold on. That was my son sending me ridiculous pictures. And he made a little gnome, and he sent me, he's like, it's the cutest kid. He's the cutest kid in the history of children. He made a little gnome out of polymer clay, and he sent it to me, and he's like, Mom, it's Noam Chomsky. I was like, I love you so much. Because he's one of my favorite political philosophers, and my 10-year-old knows that. Okay, so the sympathetic and the parasympathetic, you've got different lengths. So do you see why there are no chain ganglia in the parasympathetic nervous system? Because they're not going to line up at all. Okay, so now I don't usually ask you much about neurotransmitters, but just conceptually before you get into physiology, I want you to know that if you have two different branches of the nervous system innervating the same organ, like the heart, for instance, you can't cause two different effects on the same tissue by releasing the same neurotransmitter. Yes? So that means that the sympathetic and the parasympathetic nervous system must release two different neurotransmitters, and they do. The sympathetic releases norepinephrine, also called noradrenaline, and the parasympathetic releases acetylcholine. That's how they can cause two different responses on the same tissue. And you get into that in excruciating detail in physiology, so that's just your first introduction to it. Okay, so the last thing that we're going to do is we're going to go through just sort of a survey of some functionality that goes with the anatomy of the sympathetic and the parasympathetic nervous system. We're going to start with parasympathetic nervous system. And we are going to confirm that the parasympathetic nervous system, all innervation to effector organs comes through 4 cranial nerves, nothing until you get to the sacral region of the spinal cord, right? Okay, so when you guys did cranial nerves, you learned some of this functionality, but most of the functionality you learned with cranial nerves was somatic innervation, like controlling skeletal muscles, right, and facial muscles or sensation. So some of this will be adding to the cranial nerve innervation that you learned. It's not telling you that the other stuff is wrong. It's just like, in addition to controlling the extraocular eye muscles, you are also going to control pupil constriction and curvature of the eyeball, right? So, before we go any further, 4 cranial nerves are going to be responsible for the vast majority of parasympathetic innervation, okay? And I want you to tell me what the names of these cranial nerves are before we go any further. Cranial nerve number 3, oculomotor. Cranial nerve number 7, facial nerve. Cranial nerve number 9, glossopharyngeal nerve. Good. And cranial nerve number 10, vagus nerve. Okay, so let's look at some functionality, some parasympathetic functionality, going to what kind of tissues? Smooth muscle and glands, because your heart ain't up there, right? Although cranial nerve number 10 does do heart. Okay, primarily smooth muscle and glands. And before we go any further, again, parasympathetic activity is which? Fight or flight or feed or breathe? Feed or breathe. So this should be stuff that you can afford to do when a bear is not chasing you, right? Okay, so the way my brain works, you can do it any way you please, but the way my brain works is just to remember that with the sympathetic nervous system, there's a finite number of things that you're willing to spend ATP, glucose, and oxygen on. And those are easy for me to remember. And then the parasympathetic nervous system does the opposite. So if you can't remember all parasympathetic functions, remember sympathetic functions. And then parasympathetic does the opposite. So the oculomotor nerve, in addition to doing the job that you learned in your lab manual, which is controlling the activity of the extraocular eye muscles, which you're going to learn this week when you do the eye, they also control smooth muscle that's responsible for pupil constriction. And that was in your lab manual, but not all of this stuff was in your lab manual. Pupil constriction. So if pupil constriction being a parasympathetic function doesn't make sense to you, then ask yourself whether pupil dilation being a sympathetic function makes sense to you. There's a bear. I want to see the bear, right? Okay? You're like, freaking bear! Yes. So pupil constriction is a parasympathetic activity controlled through cranial nerve number 3. In addition, controlling the curvature of your eye for focusing is also a smooth muscle activity controlled through cranial nerve number 3. Good? So that's the oculomotor nerve. And it even goes with the name oculomotor, right? It's just controlling smooth muscle activity in addition to skeletal muscle activity. Facial nerve. In addition to doing most of the facial nerve stuff that you learned, which is controlling most of the muscles of facial expression and most of the sensation in the face, in addition, the facial nerve also controls glandular secretion, most of it, in the face. And the glandular secretion is primarily tear secretion, not like crying, like moisturizing your eyeballs, right? And nasal gland secretion and most of your salivary glands, not all of them, but most of your salivary gland secretion. Okay? Okay. Now, all of those things are things that get turned off during fight or flight responses. You probably don't notice the tear secretion getting turned off, but you probably do notice the dry mouth. You ever had a really, really bad job interview? That's a fight or flight situation, and your mouth dries up, right? Or you're super nervous about something, or you almost get into a car accident. The fascinating thing about the autonomic nervous system is we respond the same to physical and emotional stressors, exactly the same, okay? For that matter, it also happens even when it's not a negative stress, it's a positive stress. If you get in the same room with somebody that you are ridiculously attracted to, your pupils will dilate and your mouth's going to dry up and your heart rate's going to go up and you're like, I don't think this is a good technique. It's definitely not, right? Okay, now the glossopharyngeal nerve, of course, is going here. And what it does is innervates the other salivary gland. I don't know, you haven't learned the names of the salivary glands yet, but that big honker right there, it's called the parotid salivary gland. Okay, so the other salivary gland. And then the vagus nerve. Look at how hard the little vagus nerve works. Look at what it innervates. It innervates the vast majority of stuff in your anterior body cavity until you get down to the distal end of your intestine and your pelvic cavity, right? So that is controlling normal functionality of the vast majority of your digestive functionality and your even a little bit of your reproductive and your heart rate and all of that kind of stuff that's controlled through the vagus nerve. So the vagus nerve, if you think about it, can you imagine why if someone had a really low spinal cord injury with regaining, like still retaining a lot of functionality like L1 or something like that, T12 to L1 or something, can you see why they would retain almost all normal functionality, right? And they probably even retain all sympathetic functionality too, or at least most sympathetic functionality, because most of it actually comes from a cranial nerve, which is coming up here from the base of your brain. So you retain most of that functionality. Now, go ahead.
So what is a VNS doing when someone's having a seizure?
I don't know what that stands for.
Vagus nerve stimulator.
Vagus nerve stimulator. Vagus nerve stimulator can slow down the action of the heart and can slow down the innervation of the muscles and glandular secretion in the anterior body cavity. Does that make sense? Okay, so let's talk briefly about a vasovagal response. Have you guys heard of a vasovagal response? It's probably why Elvis died, right? So the vagus nerve runs through, you can find them in the cadavers. I think you should. You should go look for the vagus nerves in the cadavers if you haven't found them already. And what the vagus nerve does is not increase heart rate, but decrease heart rate, because this is parasympathetic activity, right? But if your vagus nerve gets overstimulated, it can decrease your heart rate below what you want your heart rate to be, and therefore you're not delivering adequate amounts of blood flow to places. In addition, it can also cause vasodilation, which will drop your blood pressure more. So that response in which, if in some body positions, straining on the toilet, because you hadn't been eating anything but marshmallows, right? So straining on the toilet, people have heart attacks all the damn time on the toilet. So make sure you're wearing pretty panties, that's all I have to say. If you're fat, make sure you wear good underwear. So that vasovagal response can compress your vagus nerve and can actually slow down your heart. And it's not going to kill most of you because you've got a healthy cardiovascular system anyway. But if your cardiovascular system is otherwise unhealthy, this can actually cause, go ahead.
Super stupid question.
Yeah.
But in some cases when people get heart attacks, they also crap their pants. Does this have to do the same thing?
It doesn't have to do with sympathetic stimulation. It has to do with it can have to do with sympathetic stimulation, but it's also loss of your voluntary control of your skeletal muscle sphincter at the bottom. So they were like on the verge of pooping anyway, right? And it was like all loaded up. And then you just like let it go, right? But it does happen, yes. And it doesn't just happen with heart attacks. It happens with all kinds of injuries. And even childbirth. Yeah. Sorry, I always like I teach one of my classes is half advanced high school students in the spring, right? No, fall every year, and I always like teach them that. I swear it's the best birth control ever. I'm like, you're gonna mess up all your junk and you're gonna poop, and they're like, oh my God, no!
My wife's been debating on whether or not to let me participate in the childbirth process this time because she pooped one last time. I didn't tell you that.
No, and I'm not at all gonna mention it to her when I see her immediately after class.
This is not being recorded or
Don't listen to that. Don't listen to this in her presence. Okay, so
they just like shuffle that stuff aside so the woman doesn't know.
Oh.
Like a lot of times you don't even notice. They just like hide it and then they don't say anything.
well, especially if you've had an epidural, then you're not going to notice. But if you haven't had an epidural and you're having a natural childbirth, you are going to feel the poop process occurring.
And if they have the mirror there too.
Oh,
Are you
yeah.
using like the same muscles to push like it out?
It's not exactly the same muscles, but it's the perennial muscles, and it's
Yeah.
really hard to push that hard and not actually. Yes.
Pelvic
Yeah.
floor.
Yeah, it's the pelvic floor. Yeah. So just so you know, sex, destroy your junk, and pooping, especially if you're a 17-year-old and I'm trying to convince you to wait. But most of you guys are not. It's really awkward to teach the reproductive system to this group of 17-year-olds who are incredibly bright, but Utah has abstinence-only sex education, so they have literally never heard any of these words before. None of them. You should see what Utah allows people to teach in public school for sex education. It's tragic. In Provo, I'm going to shut up in a minute, but in Provo, they're not even allowed to acknowledge that sex occurs ever outside of marriage in all of Utah County. And some of those kids, like their parents aren't married, and they're like, how the hell did I get here? Okay, all right, so that's the vagus nerve. The vagus nerve can also be stimulated by body position. So sometimes if you're just really slumping over, it can stimulate the vagus nerve as well, and you can have heart problems associated with that. Okay, so let's talk about the parasympathetic effects that come through down here. And then you can sort of, if you think about spinal cord injuries, you can see how, although you retain this functionality with even a really, really high paraplegic spinal cord injury, like T12 to L1, you are going to compromise some functionality, right? And you're going to compromise the functionality that comes from the sacral region of the spinal cord. And the functionality that you're primarily going to compromise is defecation, urination, right, and reproductive activity. There's a tremendous amount of variability how much of that you're going to lose. So I'm not saying that you've lost all functionality. But generally speaking, defecation is still going to occur, but you're going to have a problem with the last part of it, right? You're still going to have peristalsis going through, but you're going to have a problem with the last part of it. If your abdominal muscles are still functional, then you can have that pushing. A lot of times what happens is people have to time their defecation. It has to happen at very regular intervals. And the same thing with urination. You may not have to be catheterized, but you may have to be very careful about your urination sort of schedule. And then what about uterine contraction and erection? There's a decent amount of variability in there. Women can still get pregnant if they are paraplegic because the pregnancy process is not a nervous system phenomenon, right? That's why, although it's tragic, women who are unconscious, right, can actually become impregnated, and it has happened multiple times. Now, what is probably not going to happen is you're not going to be able to deliver that baby vaginally, right, because you don't have the uterine contraction to make that occur. And there are exceptions to that. Sometimes you can lose partial functionality and you still have the capacity to do that. How about erection and ejaculation? It's variable. There are other ways to actually cause an erection to occur. Sometimes with digital stimulation, especially if you get visual confirmation that it's going. So if you have an adult male who has been sexually active and then he has a spinal cord injury, the presence of an attractive woman, right, and the association of the fact that an attractive woman is touching my penis can cause an erection, right? Because it's not just as simple as sort of this parasympathetic innervation. In addition, there's some hormonal components. There's other ways to get the messages down there. So it's not as if it's an absolute no, but it's not going to work via the same circuitry that it worked before. And there's no guarantee that it can work. And of course, there's lots of other things you can do. You can install a penis pump too. One of my first cadaver that I ever dissected had a penis pump. And the first place that I ever dissected on my first cadaver was his groin. I don't know. I'm me, I guess. I don't know. I was like, oh, I wonder what's in here. I was so confused because there were like tubes and they were incredibly symmetrical. And I was like, what the hell? And I'm like talking. I'm like in the inguinal canal and I'm like, vas deferens, testicular artery, testicular vein, testicular nerve. What the hell is that? And I was so embarrassed. And there were a bunch of smart people around me, a bunch of anatomists. And I was like, who's this? And they came over, and luckily nobody knew. Everybody was like, what the hell? And they have little, they put little bulbs full of fluid in the scrotum, and then you just squish them, and it pushes fluid, hydraulics, and it still works after they're dead. I don't know how I know that, but I do. I do. I did. They walked away, and I was like, we're not going to test this? And I was like, they're like, you're going to do that? I'm like, of course I'm going to do it. I'm a scientist. And then I got home, and my sweet husband said, see, sweetheart, you can even give a dead man a boner. And I'm like, I love you so much. This is definitely going to last. Okay, so sympathetic activities. Let's talk about sympathetic activities. Okay, so sympathetic activities, obviously this ganglia and the structures that are involved, each of these ganglia has a name. Actually learning the complex anatomy of the sympathetic nervous system is a beast. So we are just going to learn it in this kind of detail, and if, for instance, you take neuroanatomy in the future, you would learn it in excruciating detail. Even finding these on a cadaver is so freaking hard, especially the ones that are like sort of in back here. They're really hard to find. Okay, so let's just talk about functionality in general. Of course, this is fight or flight functionality and fight or flight functionality to cardiac muscle, smooth muscle, and glands. The sympathetic effects on target organs, it's all motor activity, and they all go through the thoracic and lumbar regions of the spinal cord. And so what is going on here? Well, things that would help in an emergency situation are going to be increased. And pretty much everything else is going to be decreased, right? Because if you think about it with finite resources, you have a finite amount of blood, 4 or 5 liters, right? You have a finite amount of oxygen and a finite amount of glucose, so you don't want to send it to places that could not help you in this situation. So if you got like 2 minutes left to live, where do you want to spend your last ATP when there's bear in the room, right? So what you do is you tend to turn down most tissue. So I can, like, if you have that in your mind, I can tell you a tissue that you haven't been taught specifically before, and I can ask you, what do you think the effect of the sympathetic nervous system is on uterine contraction? Increase or decrease? Decrease, because you can't afford it, right? What do you think it is on cardiac muscle contraction? Increase. What do you think it is on salivary gland secretion? Decrease, right? So you can figure it out just by resource allocation. And most of the time you're going to be right, although there's some weird stuff that's counterintuitive. I'll tell you in just a second. Most of it's pretty intuitive. So it stimulates cardiac muscle contraction, of course. That's going to make sense, right? We need more blood flow. How does this one make sense? Causes dilation of your bronchioles. More air, exactly, more oxygen. It inhibits the activity of your digestive glands and organs because you can't really afford it right then, and it's not particularly important to do right then. It stimulates your sweat glands, not because that's particularly helpful, but just because the other stuff tends to increase your body temperature so much. And this is like a homeostatic response. And then this one is kind of interesting. What it does is the sympathetic nervous system changes blood flow patterns so that you send a disproportionate amount of your blood to just a few places. Hey, you got a heart pin on. Yeah. It's a good day for it, so we're about to start the heart. So it sends a disproportionate amount of blood to just a few places. Skeletal muscles, right? Heart, brains, and lungs, and everything else goes up, right? And so the net effect is that you do more vasoconstriction than you do vasodilation, right? Although you do vasodilation, for instance, skeletal muscle into the heart, into the lungs. The net effect of that is it's going to increase your blood pressure, correct? Of course, you're also increasing your heart rate, which will increase your blood pressure. So not surprisingly, when you have a sympathetic response, your blood pressure tends to raise, okay? And it's supposed to. Go ahead.
So usually stress or getting scared when you get labor, but can't it stimulate sometimes?
Can it?
Well, yeah, from what my wife is like sometimes.
I don't know. I'd have to look that one up. So pregnancy is super duper weird, and it changes the wiring because of the hormonal environment. So that may very well be true. And still counterintuitive, because pregnancy, like you're being hijacked by a little parasite. And they change your hormonal environment, which changes the response to almost everything. So I'm going to have to look that up.
It makes sense that you wouldn't mind a baby if the bear's chasing you.
Yeah.
Have baby later.
Yes, exactly. Hold it in.
Yes.
Hold it in. There's a bear.
Not to kind of go backwards a little, but you were talking earlier about the whole being paraplegic and then, inserting a penis pump. What about ejaculation? How would they know? Because the body's, if you're all screwed
See it.
up,
You're like, I just ejaculated.
how would the body know to do it if it's the nerves
It's-
that's damaged?
Well, not all of it is nervous. Some of it is hormonal.
So just by
And hormones actually are through the bloodstream. So there are entire variability. In addition, you don't have to damage all of the fibers, right? So some people have absolutely no ability for spontaneous erection or ejaculation, and some people do have some. But it's a combination of two different
It
things.
depends on the injury.
It depends on the injury, yeah, it does. And it depends on where the injury and how complete it was. You don't completely transect the spinal cord. Sometimes you, for instance, lost a lot of sensory function but have motor function that's on the anterior aspect, right? So it's really variable. Sweat glands. Okay, the last thing, and this is important to understand conceptually, is that you can take a stress response and make it last for a lot longer if you stimulate the adrenal medulla. And the adrenal medulla is the middle part of the adrenal glands. And if you, for instance, almost die, so you're driving on I-15 and somebody almost kills you, and you see your life go before your eyes, and you are absolutely certain this is the last moment of your life. And it's a big, big, big stress, not a small one. Then what happens is your nervous system says, okay, this is a big job, and I need to involve the endocrine system. And what it does is it causes the adrenal medulla to dump epinephrine, adrenaline, into the bloodstream. And once you dump it into the bloodstream, it has the same effect on all of the target tissues, plus some more effects. And it's cheaper to do that than to repeatedly release it as a neurotransmitter. It's cheaper to dump it as a hormone than to repeatedly release it as a neurotransmitter. But that also has some implications. It means that you can't turn it off as quickly. Because after you dump it into the bloodstream, you have to clear it by breaking it down, generally through the liver and the kidneys. So the effects, depending on how much you dump into the bloodstream, can last for up to 30 minutes. So you figured out you weren't going to die. Does your heart rate go back down? No, not very quickly, right? And your mouth is dry, and your pupils are huge, right? And your heart rate is high, and it stays that way for a while after you dump it into your bloodstream. Does that make sense? So that's the endocrine aspect. You get your endocrine system involved, and then you really can't turn it off. And you experience this in your daily life. If you're a parent, you experience this every time your kids throw a fit. So if your kids throw in a fit, just so you know, they will generally activate this endocrine response of the fight or flight response. And they're going to dump some adrenaline into their bloodstream. They're throwing a livid fit. And then you start yelling at them to calm down. Literally physiologically impossible. They are not going to be able to calm down. So you need to give them a place that they can flip out, right? Like, don't hit the dog, don't hit your sister, do not curse at your parents, go in a room, punch a pillow, right? Make sure it's your pillow, and then come back out because you just can't calm down. You've probably had this experience in arguments with someone that you care about. Have you ever gotten like super duper primed for an argument? Like, I got all my data, right? Ready. And I go up to my husband, or to somebody, and I say, sweetheart, we got to talk about this. Because every time you do this, this happens, and this happens, and this happens. And I'm all ready, and I've got the whole thing planned out. I got a PowerPoint. And then he goes, you are so right. I'm sorry. And then you're like, what the hell am I going to do with all this preparation? And then you can fight, and you're like, I don't like the way you said that. Yeah. Right.
So if people have like PTSD, is that
Massive, repetitive sympathetic nervous system stimulation without normal, without average, typical stimuli, right? So what happens is your sympathetic nervous system is totally primed. It's primed because with PTSD, what happens is the amygdala, that little part of your brain that is surveillance and fear, the amygdala loves to click on your sympathetic nervous system, and it does it repeatedly and with unconventional stimulation. The same thing with anxiety disorders. With anxiety disorders, if you have a panic disorder, what happens is sometimes you can't even freaking tell because like nothing in your cerebral cortex said go crazy, but your amygdala is like, I think something's gonna happen, and just turns it on, right? So it's sometimes devoid from your conscious thought. And with PTSD, it has been reinforced to be devoid from your conscious thought. Cognitive behavioral therapy can be sometimes helpful with that. Interestingly, one of the therapies that has been really, really effective is very controversial. Guess what works? So like with really resistant PTSD, clinical treatments with ecstasy, MDMA. So you need to get through the barrier in which you can like explore what occurred. And so with a nurse and a doctor, you take someone in and the barrier is removed because of the massive amount of serotonin. You can talk through it. You can explore what's the worst that could happen. You can talk about why it occurs. And interestingly, the people who have done, first they started with rape and violent crime survivors. And then the second round of clinical trials that they did were with soldiers. And the results were retained from 4 sessions once a month for 4 months, were retained 2 and 3 years out. They didn't lose their results. So it'll be interesting. Of course, you won't be able to get that in Utah. You're going to have to go to California. So even when it's absolutely legalized, and it's pretty close to being legalized. Okay, so that's the whole adrenal medulla, dumping it into the bloodstream. And when this happens, you just need to clear it out. We're all very different about how our sympathetic nervous system reacts because your stresses that would cause fight or flight response are not the same as mine, especially if you look at 2 extremes. Like I have literally never had anybody pull a gun on me, right? But what about a soldier? And what about a cop in Compton, right? That is not going to produce the same quantity of fight or flight response when you have massive amounts of training. Some of you guys would hate standing up in front of here and you would have a massive fight or flight response. And I'm fine with it, unless of course you ask me to talk about anything but biology, and then I'm absolutely not fine about it. So it's really based on your prior experience, and but once it occurs, the physiology is consistent, whether it's because you're attracted to someone or you're on a roller coaster or you're about to die. It's all the same. Okay, all right. So let's move to cardiovascular system, which is what you guys are going to start on Friday. That's not what I wanted to do. Cardiovascular system is usually good for most people. I think I suspect that the reason it's good for most people is because the combination of the fact that if you had any anatomy exposure before in any class, you'd probably get a little bit of cardiovascular system. In addition, understanding the structure implies the function. So you're like, I got a tube, I got a pump, I got some tubes, it's gonna go that way, right? You're like, I totally get this. And because of that, the retention tends to be pretty good. So what you are going to learn is the name of some terminology that you haven't learned before, a little bit more detail. And then I'm going to try to use the fact that the anatomy is usually pretty strong in people to reinforce the physiology so that you can start to, as it'll lead into physiology. So instead of, for instance, me asking you just what that vessel is called, I will ask you which direction blood is flowing through that vessel and what is the gas content in the blood in that vessel. And with that good background in anatomy will give you a phenomenal lead into physiology. So physiology, cardiovascular physiology would be easier. Okay, so before we get into the nitty-gritty of the cardiovascular anatomy, what I want to do is start to talk about sort of the plan of the cardiovascular system. And the way to talk about the plan, well, there's a bunch of ways to talk about the plan of the cardiovascular system. But what I'm going to do is, before we get into anatomical structures, I'm going to make sort of a functional diagram of the cardiovascular system so that you can sort of see the why before you put in the what. And we're going to start with drawing the heart in the simplest way possible as a box with 4 chambers within it, okay? And we will learn specific names of structures and actually what the anatomy looks like in just a second. What I want you to see is why is blood flowing the direction it's flowing, what's the gas content, and what happens when you're attached to a ventricle versus an atrium. Okay, so first thing is, you guys already know this, the upper chambers of the heart are called what? Atria, yeah? And so this is supposed to be the patient, so that is the right atrium, right? And this is the left atrium, good? Left ventricle, right ventricle. We'll add in specifics about valves and all of that kind of stuff later. But a lot of people describe the heart as a pump, but what I would argue is in a healthy adult, it's actually 2 side-by-side pumps that don't directly communicate with one another. They only indirectly communicate with one another. Talk about holes in the heart and stuff. So what I want to do is, arbitrarily, you could really start this at any chamber, but I'm going to start with the left ventricle. And the reason I'm going to start with the left ventricle is that the blood that is leaving the left ventricle is headed for every organ in the body except the lungs. So the left ventricular function is a really good predictor of blood flow as a whole. Okay, so first thing is I want to get rid of a term that people have used incorrectly very, very frequently. I was even taught it incorrectly when I was growing up. A lot of people define arteries and veins as arteries carry oxygenated blood and veins carry deoxygenated blood, but that is not the definition of an artery or vein. The definition of an artery is that an artery carries blood away from the heart. So the ventricles are pumping chambers. They are going to be very thick-walled. When you get to look at a fresh pig heart either Friday or next week, I want you to note the thickness of the ventricle versus the atrium. The atrium just feels like skin. It's really, really thin-walled. The ventricles, especially the left one, is really hardy. So these are pumping chambers. So any vessel that is directly attached to the ventricle is going to be leaving, right? The blood is going to be leaving the heart. So an artery is defined as carrying blood away from the heart, right? All arteries can be traced back to a ventricle because the ventricles are the pumping chambers, okay? So that is an artery. Now, conceptually, you can probably figure this out even if I didn't tell you. If this left ventricle is pumping blood to every organ except the lungs, tell me the gas content, meaning high what, low what?
High oxygen.
Yeah, high oxygen, low carbon dioxide, of course. Okay, so this is again a functional diagram. I'm not saying that everything it pumps is below the heart. Collectively, this blood is going to what I'm going to call the systemic capillary beds. And that includes the capillary beds of the brain and all of your skeletal muscles and all of your intestines and all of that kind of stuff. So Something else that's functionally important that you guys need to understand, if you don't already, is that the only place that you get any appreciable amount of gas, nutrient, and waste exchange is at capillary beds, because capillary beds are thin and have tremendous surface area because of how branched they are. Meaning that you are not going to see gas exchange occur within the chambers of the heart, no, and you're not going to see it occur in an artery or a vein, but you are going to see it occur as it goes through a capillary bed. So when you come out the other side of this capillary bed, what's going to be the gas content? Yes, low oxygen, CO2. And I know that you know this, but I want you to verbalize it. So put it together with 1610 and tell me why. What the hell is going on in those capillary beds that's sucking up the oxygen and generating carbon dioxide? Cellular respiration, exactly. So you are using up oxygen for cellular respiration and you are generating carbon dioxide. And by the way, in direct proportion, if the tissue is more active, you're going to use oxygen more quickly and generate carbon dioxide more quickly as well. Okay, so that should make conceptual sense. Now, this blood is good for nothing, pretty much, right? Okay, so the only logical place to send this blood is where? Back to the lungs, but it's super low pressure by the time you get to the other side of the capillary bed for multiple reasons. Really far away from the pump, lost some volume as it goes through the capillary beds, and also veins have a bigger lumen. So it's super low pressure. And so what is going to happen is, in order to get it to effectively go to the lungs, reasonably quickly, what we're going to do is we're going to have to send it back to the heart and give it a pressure bump. Okay? We're going to send it back into the right atrium. This vessel right here is delivering blood to the heart. Because of that, it is called a vein. Okay? Veins are defined as delivering blood to the heart regardless of their gas content. Good? Okay, so now I'm in the right atrium. It's a receiving chamber. The atria will deliver blood to the ventricles. It's going to go straight through, right? Good? And then the ventricle is going to bump up the pressure again. And the blood that leaves the ventricles, right here, is going to be going that direction, valve to be named later. What kind of vessel is that? Yeah, that is an artery. But please note that that artery still has what gas content? Low oxygen, high CO2. So do you see why my 7th grade teacher did me wrong? By trying to teach me that arteries carry oxygenated blood. So why the hell did she say that? The reason that she said it is there are way more arteries carrying blood to all organs except the lungs, right? So most arteries are oxygenated, right? Then there are a few arteries that are carrying blood just to the lungs. So the vast majority of arteries that you're going to run into in the body are oxygenated, right? But that's not why they're an artery. Why they're an artery is because of where they're carrying blood. So this artery is, of course, going to the only logical place to send blood like that, which is what? Lungs, yes. It's going to the lungs. Draw a bad picture of lungs. And specifically what it's doing is going to the pulmonary capillary beds. And as you go through the pulmonary capillary beds, gas exchange occurs. So what can you tell me about the blood that's coming out the other side of the pulmonary capillary beds? High oxygen, low carbon dioxide. By the way, it never gets to 100 and 0. It's always just high versus low. And then where do you send that? Send it back to the heart. Okay? Into the left atrium. Left atrium delivers it back to the left ventricle. And then the whole thing starts over again. What you end up with is two sort of interlocking circuits. Do you see them? Okay. This circuit goes from the left ventricles through systemic capillary beds back to the right atrium. This circuit is called the systemic circuit. And this circuit goes from the right ventricle through the pulmonary capillary beds back to the left atrium. And that one is called the pulmonary circuit. So which one has massively more vessels than the other one? The systemic circuit. Which one's more important? Yes. Both of them. Which one do you generally have cardiovascular problems with, though? Usually. No, it's usually systemic. Systemic has so many blood vessels, and there's so much opportunity for gunking them up. Like hypertension generally occurs in the systemic circuit, gunking up your arteries with arteriosclerosis and atherosclerosis. And of course, it has to generate way more pressure too, right? Because you got to go a lot further, right? The other one is a way lower pressure. And at lower pressure, you don't tend to have as much damage in the vessels and all that kind of stuff. So it's not as if people don't have pulmonary circuit problems, but far more problems occur in the systemic circuit. There's more places, it's higher pressure, all of that kind of stuff. Is that all right? Okay, so we will label all these valves before we're done with this. So what that is showing you is the same as what this is showing you. The only thing I don't like about this when you introduce it is that it sort of looks like you have two systemic circuits and two pulmonary circuits when you really don't, right? Of course, part of the systemic circuit is below the heart and part of it is above, right, anatomically. But I want you to understand that really there's one systemic circuit and there's one pulmonary circuit. Okay, so now, I told you that I thought of the heart as two pumps side by side because in a healthy adult, there are no holes between the left and the right. And the left heart will exclusively be dealing with high oxygen blood, and the right heart will exclusively be dealing with low oxygen blood. If, as does happen sometimes, somebody gets a hole in their heart, it's usually right there because of developmental reasons. I'll explain later. And how do you compensate for that? Well, if you don't have a good separation of oxygenated versus deoxygenated blood, then you're sending sort of mixed blood to your organs, right? Which, of course, compromises the efficiency, right? And so what's going to happen, if that is an appreciable amount, is you're going to have to compensate by increasing the cardiovascular flow, which is hard on your cardiovascular system. You're going to have to pump harder and or more frequently. Does that make sense to you? So if someone has a big hole in their heart, a lot of times they'll go in and do interventional surgery, right? Now, what if it's teeny tiny? Well, if it's teeny tiny, then sometimes the surgery is a bigger risk than leaving a hole in your heart. And also sometimes with babies, the hole will close itself with just like sort of maturation and development. But sometimes they can choose to go in and change it. So the left heart receives blood from the lungs and pumps it to the other organs, and the right heart does the opposite. Receives blood from other organs and pumps it to the lungs, right? Okay. All the blood running through the left heart, always oxygenated, always deoxygenated in a healthy person, okay? And then, so systemic circuit, in the systemic circuit, can you, without looking, tell me which chamber blood starts in the systemic circuit and which it ends up in? Systemic circuit goes where? Left ventricle to the right atrium. And pulmonary? Right ventricle to the left atrium. Good. That makes sense to you guys? Okay. So, now, briefly, what about the vessels involved? And we're going to get into vessels in more detail in the next set of notes. What is an artery versus a vein? And even more importantly, what's an arteriole and what's a venule? So the general blood flow pattern in the cardiovascular system, with a couple of exceptions, is this. Heart, really ventricles, arteries, arterioles, capillary beds, venules, veins, heart, right? That's the pattern, okay? That's the order that it goes in. So what's the difference between an artery structurally and a vein? Well, arteries tend to have a lot more musculature and a lot more elasticity in their walls. Does that make conceptual sense to you? Can you explain to me why you would need more musculature and elasticity in your walls? The pressure is high, but the pressure is also super variable, right? So arteries receive blood in big pressurized squirts, and then very little pressure between. Squirt, right? So they have elasticity and they snap back, right? Veins, however, receive blood from the backside of capillary beds, so they're receiving blood in trickles, right? And I don't know if you guys know this, but you can, of course, detect your pulse in an artery. You can detect almost no variation in pulse in veins at all. So they have no real detectable pulse pressure. Does that make sense to you? So they receive blood in pretty continuous flow back from your capillaries. So the arterioles are simply the very smallest arteries, and luckily you don't have to know them by name because there's too damn many of them. They're almost invisible with the naked eye, and they're really variable between people. What you guys will learn is, of course, the blood flow coming from the left ventricle and the aorta, and a bunch of the arteries that are supplying major places in the body. Go ahead.
So this is kind of weird question, but when you're giving someone a shot,
Mhm.
you give it through their artery. Is that correct? Is it-
Usually given in the vein.
Oh, in the vein. Okay,
Uh-huh.
so if you were accidentally to give it through the artery, what happened?
Nothing much except you probably get squirted in the face.
That's it. Okay.
Yeah, and also arteries have a bit harder time clotting because there's so much pressure, it washes away the clotting factors.
Okay.
So
They would just
usually, they do not usually puncture arteries unless they can't do it through a vein. I mean, but sometimes they have to, you have to put in like a central line or something like that. You have to do. Then capillaries are, of course, the smallest diameter and the most branched, and that's where gas and nutrient exchange occurs. As you go through a capillary bed, you're going to see a change in the color of blood. If you're in the systemic circuit, it'll be redder on the arterial side of the capillary bed and then less red. It's not ever blue. And then venules are the smallest veins that pick it up from the other side of the capillary bed, and those they're not named, okay? And then the veins are thinner walled, less musculature, less elasticity than arteries. And although it seems counterintuitive, they're also wider lumen than an artery. And the lumen size has to do with maintaining pressure. Because if an artery has a really large lumen, can you see that that will actually compromise the directionality of the flow, right? So if you get a pretty fast flow through a stream, but how about through a lake? Right, it slows down the flow. So you need decent enough pressure in the walls to keep the flow unidirectional. But when you're in a vein, are you really in a hurry? No, you're not. You're like on your way to work through an artery, right? And you're always almost late, right? Within 5 minutes of being late, right? So you're on your way there, right? And you need to get there relatively directly. There's also a lot less variation in patterns in arteries because evolutionarily there's a lot of pressure to get there quickly, not fart around on your way there. But in veins, you're on your way home, and somebody's just going to make you cook something or clean something as soon as you get home, right? Someone's going to need something from you. You might as well go to Target, right? Don't need to speed either, right? You're like, I'm just going to fart around. On your way home, they're way lower pressure. Bigger lumen. There's way more variation in veins too. Tons more variation. Between you and me, arterial variation would be, I don't know, I'd say that if we looked at our arterial variation, we might find 5 arteries that varied with the major arteries. But with veins, we would have variation in every single limb. There would be variation, which makes it a little difficult for anatomy students. You're like, what the hell? You said it was going to be here. And we're like, well, 45% of the time it's going to be there. Okay, and let me show you just this figure before we get into the heart in detail. So please also notice that because of the difference in the thickness of the walls, if you look at the biggest arteries and veins, they're the ones right by the heart, you can actually immediately tell what's an artery versus a vein. Do you see this one that's almost flat, ribbon-like? That's a big old vein. See this one that stands up and lets itself be known? That's an artery. Okay, so you will get used to being able to tell the difference between them. Go ahead.
So are veins like the simple squamous?
On the inside.
On the inside?
They're not just simple squamous epithelium. They actually have connective tissue in the wall. Both of them have connective tissue in the wall, simple squamous on the inside. But it's just that between the simple squamous and the connective tissue, an artery has a big layer of muscle, yeah, and some elastic connective tissue, and a vein has less muscle and less elastic, sometimes even no elastic connective tissue. Okay, and we'll do the structure of arteries and veins in the next chapter. Go ahead.
Just really quick. So the blood vessels we see on our body,
Mm-hmm.
they're all veins.
Yeah, so this is interesting. So conceptually, like in my hands or your hands, the things that you see superficially, we have a lot more superficial venous drainage than we do superficial arterial flow. Can you understand how evolutionarily, if you had arteries close to the surface, it would be very difficult for that to be conserved, right? So your arteries do not tend to be very, very superficial. Any nick in an artery, you're less likely to survive it. So this is all superficial venous drainage that you've got here. Okay, the arterial flow to the same places comes from the underside, but the venous drainage can go back up the opposite side.
So are there arteries you can palpate from?
Yes, you can palpate a few arteries here. You can palpate some here, and the popliteal region.
So you can pulse that back.
Yeah.
Okay.
Yeah, wherever you can feel a pulse, that's an artery that you're feeling. Don't do both of these at the same time. Because these two, the carotid arteries, both of them combined, you can feel them if you don't use your thumb. That's 75% of the blood flow to your brain between these two. Okay. So did you guys ever do the like thing when you were, anybody do that? What's it called? The pass out game?
Yeah, I did that. That was back
Yeah.
when we were kids.
That's
They
terrible.
were kids.
I'm pretty sure I did it. I made every bad choice at least once. So that's compressing your carotid arteries to your brain. And people are doing that because they like don't want to drink a beer. Drink a beer instead of compressing your carotid arteries to your brain, okay? It's like a beer. I mean, if we got some choices here, you're like, crystal meth. Don't do that. Okay. So these are arteries versus veins. Now let's just introduce yourself to the heart, the location and gross anatomy of the heart. You guys are going to start on this on Friday. So what happens a lot of times in lab is that because you guys are going to do a heart dissection, either fresh or preserved, the fresh ones are better, but they're hard to get enough that you can all do them. And also because you have tons of heart models, what people don't do is they don't go look at the cadaver. Go look at the cadaver so that you can see the heart within the context of the human body. You can see that the pericardial sac is actually attached to the diaphragm inferiorly. You can find the sac, you can see where it is within the mediastinum. If you're really looking for it, you can even find the vagus nerve going to the heart. You should look for all of those things because you have cadavers. And most undergraduates do not have cadavers to study from. So make sure that you go look for this. So you will see the heart within the pericardial cavity. It sits right on the surface of the diaphragm. Okay, and then what we will see is when we start talking about the pericardial sac, the pericardial sac on the bottom is actually attached to the surface of the diaphragm. The pericardial sac on the top is actually attached to the great vessels. Okay, so it positions it there within the mediastinum. So where does the heart actually sit? Well, it's kind of counterintuitive the way that it sits. I mean, everybody knows it sits a little bit to the left of the midline, but that's not exactly how it sits. Here's how it sits. So if these are my two atria and these are my two ventricles, right? Here's how the heart sits. 2/3 to the left of the midline, but you're going to see mostly the right side from the anterior. So it's twisted in there. Does that make sense? Okay. So it's not sitting exactly. So what I'm saying is like even if you, this is not all left heart. Most of it is right heart that you're actually seeing. Okay. So it's twisted the way that it actually sits in there. So when your doctor is rooting around in your chest to listen for your heart, the best place to find it is over on the left side between ribs 4 and 5. Way easier to find if you don't have breasts, right? You don't have to like move stuff around up there. But the reason they listen right there is because the heart almost comes into contact with the anterior wall of the thoracic cavity. So you can hear your heart there too. If you have a stethoscope, it's really actually easy to hear it right there. So that's why they listen specifically there. It's not the only place that you can hear it though. Okay, so counterintuitively, the bottom part of the heart is called the apex. And the top part is called the base. So it's an upside down mountain, basically, right? Because the apex also means point, right? So the apex is here, and this is the base. The base is where all of the great vessels come out, and the apex is sitting over to the left side. There's a notch actually out of the left lung called the cardiac notch for where the heart actually sort of pokes into it. So the heart is surrounded by a pericardial cavity, and we learned this a while ago. So let's look at the pericardial cavity in a little bit more detail and learn one thing that we didn't learn at the beginning of the semester. Of course, we know, we talked about the fact that the heart sits in the pericardial cavity kind of by creating a cavity for itself, right? You take the heart and imagine it as, they always say the heart is the size of a fist, but it's not. It's the size of like a fist and a half, or like his fist, but not my fist, right? The heart is not that big, okay? So a dude fist, like a big, meaty dude fist, lots of testosterone in that fist. So Thanks. Testosterone's not always a good thing, but you can have that one. Okay, so, because you're big.
Thank you.
You're big. And also, by the way, if you start having heart problems, especially with hypertension, then your heart increases in size to compensate. So as a lot of the cadavers that we have, because they're elderly and have heart problems, their hearts are like enormous. That's not really normal. Well, not healthy. Okay, so push your fist into a softly blown up balloon, and then you get a layer coating the fist, and then a space, and then another layer. And that's the sort of pericardial cavity that we learned about before. And you already kind of know this, but the layer that's touching the heart is going to be called the visceral pericardium. And then the layer on the other side is going to be called the parietal pericardium. And then what would you expect to find between here? Just serous fluid, right? Okay, but serous membrane is not very thick and protective. So in addition to those two layers, you get another layer on the outside. This opaque sac on the outside is called the fibrous pericardium. And it's made of dense, irregular connective tissue, and it helps to protect, position the heart, attach it to the diaphragm, attach it to the great vessels. That's the fibrous pericardium. That's in addition to the serous membranes. Is that good? And if you don't remove this fibrous pericardium, you can't see the heart. So if you just opened up a thoracic cavity, you would see an opaque sac, and you wouldn't be able to see any of the structures of the heart. So when you guys look at the heart in the cadavers, what we've done is we've removed the anterior part of the serous membrane, both the fibrous pericardium and the parietal pericardium. But you can still see it, and you should. What you should do is get your gloves on and move the heart apart so that you can see that the back side of the pericardium is still attached to the diaphragm. You can still see the shiny inner surface, which would be the parietal pericardium, and you can still show yourself the structure of the actual pericardial sac, right? So even though you can't immediately see it, it's still there on all of the cadavers. Good? Okay, so so you've got your fibrous pericardium, your serous pericardium. I don't know why your textbook decided to change the terms on you, but you don't have to change them. Instead of calling this the parietal pericardium and the visceral pericardium, they are calling them the parietal layer of the serous pericardium. That is unnecessary. We know it's parietal pericardium. We already learned that. And this is the visceral pericardium. You don't have to change the names. The other name that is very important because it's clinically used is the other name for the visceral pericardium is the epicardium. That's kind of commonly referred to. So the epicardium. Okay, so let's talk briefly about pericarditis again. I mean, we talked about it at the beginning of the semester, but didn't really have much frame of reference at that point. So what pericarditis is when something irritates your pericardial sac, and then the pericardium responds by starting to overproduce the serous fluid. And when you do that, of course, it's going to have some impact. But look how little room there is for fluid there. And then the other thing I need to tell you is now the outer layer, the fibrous pericardium, is not stretchy. It's collagen fibers, not elastic fibers. So if you overproduce, what is it going to do to the filling capacity of the heart? It's going to reduce. And when you reduce the filling capacity, you reduce the pumping capacity, right? So you can compromise normal functionality with pericarditis. So why would pericarditis happen? We talked about this before. It's a common complication of open heart surgery because you had to damage it to get in there, right? And then pericarditis can also be a complication, and we talked about this at the beginning of the semester, I think, too, of oral health. Did we talk about this? So the two biggest predictors, other than genetics, which you can't do a damn thing about, of long-term cardiovascular health are diet and exercise. But the third one is oral health. The third one is oral health because your natural flora in your mouth, if they get mobilized into your bloodstream, because of course you have a bloom of them, and also with bleeding gums like gingivitis, they love to trash your heart. So, and they cause long-term damage to your heart. So that's a good way to scare your children into brushing and flossing. I ended up giving my son anxiety attacks about it. I was like, oh, I think I did a little too bad of a job. Because he'll get Really Rain Man if he can't brush his teeth at the right time. He's like, I haven't brushed my teeth. I'm like, it's fine. I ruined you. Okay, so that's pericarditis. So last little bit, and then I'll let you guys go because I didn't quite get to this in the other class, is that after you get through these layers, so we've got the epicardium, then what we have is we run into the cardiac muscle. The cardiac muscle is massively different in thickness between like atria and ventricles, and also between the left ventricle and the right ventricle. Anybody want to hazard a guess as to, if you don't already know, some of you do, some of you took physiology, which ventricle is thicker, and then why? Left is way thicker, why? What? No, it's not more oxygen. It has to generate more pressure, right? It has to generate about 4 times more pressure than the right ventricle does, because you're going to, against gravity, to the brain and then to all of the other tissues. That, by the way, can also help you guys understand why people who are well outside of human height or weight ranges tend to be almost predictably high blood pressure, because you have to be. Do you kind of see that? Because if I am 7'2" and weigh 450 pounds, and my heart doesn't increase in size proportionally, because it doesn't, okay? Why you can pretty much predict higher pressure in that person, and why typically being well outside of human height or weight ranges reduces your life expectancy. It's really hard on your cardiovascular system to be well outside on the high end. So last little tidbit is this. When you take a chunk of the heart, and here is your epicardium, right, and then you start moving in. Do you guys remember the tissues that make up a serous membrane? Should. Simple squamous epithelium plus areolar. And areolar, remember, can always have fat in it. If you are really unhealthy, you tend to build up a lot of fat on the surface of your organs. All hearts have a little bit of fat on them, but healthier hearts have less fat in that layer. So you can get so fat that you can't see any of the blood vessels on the surface, okay? So, and for some reason, and we don't know why, this fat is worse than any other fat. The fat that's actually associated with the organ itself tends to be worse for your cardiovascular fitness than other fat, and we don't know why yet. So this is the epicardium, and then once you move into the cardiac muscle, that's just called myocardium, right? Notice that there's a bunch of blood vessels going through it. It's super duper vascular tissue. And then once you get to the inner layer, this inner layer is called endocardium or endothelium. Endothelium when it's in blood vessels, usually called endocardium here. The most important thing about the endocardium and the endothelium in blood vessels is that it has to be nice and slippery, not lumpy. Any idea why?
Just passage of fluid.
Passage of fluid, and what will you snag? Platelets. Snag platelets and start blood clotting without actual damage. Platelets are like teenagers. You never want them to congregate unsupervised, right? So if they get caught and you're like, hey, platelet party, then all of a sudden you're throwing a clot, and you can have a, yeah, exactly. You can have a stroke or a heart attack. Good? Go ahead.
So having like a lot of areolar connective tissue, just like that,
Mhm.
doesn't necessarily have to do with like your exterior weight, right?
No,
You
it
can be
doesn't.
Pretty, like, you can be like fat on the inside, right?
Yes, you totally
Really?
can. You can be fat on the inside. A lot of that has to do with genetics, and a lot of it also has to do with metabolism. There are people who have unhealthy cardiovascular systems, but a really high metabolism,
Oh,
right? And so they tend to get chubby. I mean, later they're going to get chubby,
yeah.
honestly. But they could be building up fat onto the surface of their heart even when they're relatively thin. So your level of circulating cholesterol, and specifically your ratio of HDL to LDL,
Yeah.
is a good predictor of the fat that's going to build up inside your blood vessels and on the surface of your heart. So she's like, I'm depressed now. Thanks.
So, yeah. So,
Okay, I'll see you guys on Thursday. No quizzes for at least